Okay, so it's nice to see all of you and exciting to talk to you about the thyroid, okay? And so on our first slide, we have the butterfly, because often we get told that it's the butterfly gland, okay? And so what we hope to do is start out by telling you a little bit about the basics of the thyroid, its location, the types of diseases that we see, and then we'll specifically start to look at the cardiovascular health and how it's related to the thyroid. And then commonly how we present to each other and teach each other in the medical field is we give cases. And these cases help walk us through how realistically we see these diseases play out in the hospital, in the clinic, etc. And so, of course, we are here to educate you. So at any time, if you guys want to raise your hand and ask a question for using too much medical jargon, anything like that, we're happy to take a pause and hear that, okay? All right. So the thyroid gland is an endocrine gland. It sits at the base of the neck. It's composed of two lobes connected by isthmus. The isthmus is a Latin word that means a small strip of land connecting two larger pieces, and so you can see that here. The blood supply for the thyroid comes off of the common carotids. It does sit below the cricoid cartilage, which is what we commonly think of as the Adam's apple, and below that the thyroid cartilage, okay? And so commonly it's a difficult to palpate gland in most normal people, but once we start to see enlarged glands that have nodules or bulks of tissue, it becomes easier for the clinician, especially endocrinologist, since we love this gland, to feel, okay? And so the function of the gland is to produce thyroid hormone. There's two types of thyroid hormone that we think of commonly coming from the thyroid gland, and that's T4, and that suggests how many iodines molecules are on that hormone. So 4, of course, is our T4, and actually our active hormone, T3, has only 3 of those iodines, okay? Also, there are C cells that are found in the thyroid glands, another type of cell type, which produces calcitonin. And so those are your hormones that come from the thyroid. Calcitonin is more related to the control of calcium. And so this is actually the microscopic view of the thyroid. We can see that we have these bubblegum areas, and that's colloid. This is kind of this sticky-like substance from which thyroid hormone is released into. Surrounding it, those big circles are follicular cells. Those are the cells that produce the thyroid hormone, T4 and T3. And then you can see where there is a parafollicular or C cell that's pointed out in the center, and that's the source of the calcitonin. The other cells that we see in the stroma, or that's this tissue around these follicles, is largely vasculature. It's a very vascular gland. And so the thyroid, and just like most endocrine organs, works on a feedback system, okay? And so the thyroid produces so much hormone as it is told to do so by the brain, okay? And so the brain is able to sense how much thyroid hormone is circulating and adjust that level up and down, okay? And so commonly, if you have had your thyroid function tested, we commonly only look at that level from the brain, the TSH, and that's really one of the most sensitive markers for knowing that you have a dysfunction of the thyroid gland. When you have established thyroid disease, oftentimes we'll start checking these other free hormones. Now, there really isn't very many cells in the body that we don't think respond to thyroid hormone, okay? So pretty much every organ, every gland that you have will respond to thyroid hormone and can be affected by dysfunction, okay? But today in particular, we'll be talking about the heart and the vascular system. Okay, so I've got a picture of a myocyte, okay? Those are the cells that make up the heart. The depiction to the side can show you various ways in which the thyroid hormone can affect the cardiovascular system. It affects the cardiac output, which is the pump function of the heart. So meaning that it changes the way that the myocytes contract, how strongly they do so, and in the end, that relates to how much blood flow it's actually able to get out of the heart. There's also changes seen in the vasculature, meaning how tightly those tubes or your blood vessels clamp down or release. And so again, affecting how effectively the heart can pump and function. Down lower, you can see the liver. I think we had somebody specifically come up and ask us about this. Cholesterol metabolism is affected by the thyroid. And so having low thyroid states can cause your cholesterol levels to rise. And of course, then we would worry about cardiovascular disease like plaques which can lead to heart attack and stroke. Okay, the pituitary gland, as you can see, we already mentioned, it's the feedback loop that tells us how much thyroid hormone to produce. And then another shout out that all the organs are largely going to be affected. Okay. And so we'll start out by talking about the basic manifestations of thyroid hormone dysfunction. We're not really going to talk so much about structural disease, and if those are specific questions you have, maybe you can reach out to us after the lecture, or if we have more time. And so the most basic and a relatively common condition is low thyroid state, meaning that you do not produce enough thyroid hormone, okay? The various reasons that can happen, one is autoimmune, okay? And so that's our Hashimoto's thyroiditis, okay? Those can be seen to run in families, and typically onset, can be throughout, the lifespan, okay? You can also have destruction of the gland. The gland can be destructed by inflammation, okay? So sometimes, rarely, we can see infections. We can see certain medications that can cause the thyroid to inflame and then have dysfunction. And then more, we think of commonly when people have radiation therapy. So for example, head and neck cancers for which we treat with radiation, you can see destruction of the thyroid gland, okay? Iodine deficiency, which Dr. Greene will talk to you a little bit more about. And then, of course, post-surgical. Some people purposely have the thyroid removed, and then, of course, you can imagine that you will be deficient and rely on thyroid hormone replacement. And so I'll let Dr. Greene tell you a little bit about how this might manifest.
Okay, you can see that the whole body is affected by thyroid hormone. Some people in high school learn that the pituitary is the master gland. Well, the pituitary isn't the perfect master gland. The pituitary is controlled by the hypothalamus, and the hypothalamus is controlled by the brain. But also this lower down from the pituitary is the thyroid gland in the lower part of your neck, as Dr. Baldwin just said. But that in turn controls an awful lot of things. When the thyroid is underactive, almost everything is shut down, except for periods. They're usually heavier, very, very heavy. And some women have even gone for something like a hysterectomy, thinking that there was no other problem except a problem in the uterus, but it could be very, very heavy bleeding because of the thyroid being down. So if you can remember that the periods are the only thing that gets very heavy, you're pretty well off answering the rest of the questions about what's happening in hypothyroidism. Everything else gets low. So low is tiredness. Now, you can understand that this is not a specific symptom. Everybody in this room, if I asked you all how many of you are tired, almost everybody's going to have their hand raised. And the few of you who are weird enough to raise your hand saying you're not at all tired, and you're not at all stressed, well, you're weird. Everybody else is tired. Everybody, so it's not a specific symptom, and that's what's really hard sometimes in diagnosis, is when you don't have very specific symptoms. It's a constellation of symptoms that we think about in endocrinology. It's not just one symptom. I'm very tired, or the other thing I hear frequently is I must be gaining weight for some reason. Well, most weight gain isn't from an underactive thyroid. But yes, an underactive thyroid can lead to weight gain, at least difficulty losing weight when you're doing all the right stuff like dieting and exercising, and yet you can't lose weight. It might be the thyroid, but it's not the first thing that we think of usually for people who are overweight. So I'm sorry if you're overweight, it's not usually the thyroid. But other things can overlap, like depression greatly overlaps, thinning hair, hair loss, dry skin, patchy skin, cold intolerance, which means that you're more sensitive to cold than other people. You're always cold in a room when everybody else is comfortable. Elevated cholesterol, as Dr. Baldwin mentioned. Enlarged thyroid gland, which we call a goiter. Now, that's a very frightening word to a lot of patients I encounter. They think goiter looks like National Geographic. You can have any enlarged thyroid is called a goiter in medical leads. It doesn't mean you look like National Geographic. The goiter can be large enough to cause difficulty in swallowing, but it's usually not that big to cause difficulty in swallowing. You can have a slower heartbeat. As I said, menstrual irregularities with heavy menses, sometimes infertility, constipation with the slowing of the bowel, and muscle weakness and muscle cramps are illustrated over here. You can also say that there are male equivalents in terms of sex function too, that it could make things difficult, but sometimes along with other things, obviously. And again, very few of these things are specific, or the medical word we use for that is pathognomonic. And none of this is pathognomonic. The most telling thing on this whole slide is probably a goiter, because most people with underactive thyroids have goiters. Unless, of course, you've had your thyroid removed or destroyed or something like that, then you wouldn't have a goiter. But there are people who don't have goiters. But a goiter is a pretty good sign that it might be hypothyroidism. Yeah. Okay, so who gets thyroid disease? Well, first of all, women get it more than men. This is not quite an equal opportunity disease. So you could see it, and people as they age get more and more thyroid disease, and most of this is from destruction or autoimmune disease of the thyroid. So the pink and blue are typically men and women. You can follow it. You can see that at any age, women have it more than men, but there is an increased incidence at all these different ages. And so when you get to be over 74, the incidence in the female population really is approaching more than 15% of women can have thyroid disease, and probably most of it is autoimmune. So the people who are most predisposed to getting it are particularly people with a family history and being female and being older. And it also can go along with other autoimmune diseases, but not as commonly. So Dr. Baldwin mentioned that I was going to talk about iodine deficiency. Now, this was the natural goiter belt in the United States a bunch of years ago. I would say before the 1940s. I don't know if there's a date on the slide. And which means basically areas with iodine deficiency. So naturally, the areas which would have iodine deficiency would be the areas where people didn't have enough fish from the ocean or enough seafood from the ocean, which is a good source of iodine. So this would be the story. It's not the story at all in the United States now, but it's a nice historical image of what would be if we didn't have modern sources. So next slide, please. So this is the iodine content of various foods, and one of the things I'm going to point to the most is that iodine is present in dairy products. Does anyone have any idea why we would have iodine in dairy products? Anyone? Why do we have it in milk? This is the question I give to all the medical students, so I don't get big answers. Yes? It's not artificially added. What it is sort of artificially added. What we do with most milking products is the cow's teats are covered with iodine to make them sterile, and on the milking equipment, frequently iodine is used. So it's a consequence of artificially adding iodine in the milking. I don't know if that's true as much anymore, and maybe milk content might be lower, but as far as I know, this is safe and used in organic milk as well. It's not considered a bad contaminant, and it helpfully adds to the iodine in the diet throughout the United States, including the Midwest, which might not be able to get as much. But the other place that we get iodine from is usually in commercial bread products, because iodine or bromide, two different similar chemicals with a similar chemical structure in the periodic table, are usually added to improve the leavening of bread. So most processed bread has some iodide or bromide. So these are good dietary sources that didn't come naturally in the milk or in the bread. It's something that is added to it. And organic milk has less iodine, selenium, mercury, and zinc than milk from cows on supplemented diet. And so I guess we are also using iodine in some animal feed, especially if we use things like seaweed to feed cows, which happens. Okay, next slide. This, however, is still current global areas of severe iodine deficiency. And I like to present this, especially to the medical students in terms of global health, that there are still areas of severe iodine deficiency. And these people get terrible goiters. They get the National Geographic goiters that I was referring to before from the iodine deficiency. So this is a slide here of Nepal in the Himalayas, which is far away from any fish from the ocean or anything like that. And also there's the problem with glaciation. Glaciation now has removed the iodine and the selenium in the soil. And think of selenium as a partner with iodine in terms of thyroid hormone manufacture. So this on the top, I don't know if you can see it well, is a goat who has iodine deficiency and has a huge goiter. And these are the contaminants which also interfere with iodine in the diet. Some of the contaminants compete with it. That is a woman on the top with a huge National Geographic goiter, as I said, and children at the bottom with a goiter. And so iodine is usually used routinely to supplement the diets to prevent these horrible goiters and also to prevent mental deficiency and growth deficiency in the children who would be growing up in these areas of severe iodine deficiency. Next slide.
Okay. And so now we'll move on to talking about an overactive thyroid. And so we just talked briefly, skimming the surface of low thyroid function. And so high thyroid function also can be caused by an autoimmune condition. This is called Graves' disease. This is actually the most common form of hyperthyroidism that we see in our country, and characterized often for us by the manifestations of the eyes. You can see the prominent push forward eyes that also have to do with the autoimmune nature of this disease. Other possibilities is that you have a nodule or a group of tissue inside the thyroid gland that can overproduce hormone, somewhat outside of the feedback loop that we had talked about that normal thyroid tissue abides by. And so you can either have one or multiple of these nodules. Also, you can have exposure to iodine-containing medication, and so think of iodine as fuel for the thyroid. If you don't have iodine, you have these low states, you have this enlarged thyroid that's trying to produce hormone, and then when you have excess or exposure, like we can see in some medications, including contrast iodine that's used in CT scans, has a large bolus of iodine that can cause an overactive thyroid state. And so I'll switch back to Dr. Greene to talk about now the manifestations.
Okay, so this is just the opposite, not exactly, but you get the idea. And I said the periods go down with an overactive thyroid. So everything else seems to go up with an overactive thyroid. So that's called hyperthyroidism, or too much thyroid. So we, again, can have a goiter, though, just like hypothyroidism. And usually this goiter is different from a hypothyroid goiter because you can feel over it and feel blood rushing through it. You can sometimes put a stethoscope over it and hear blood rushing through it because it's a very, very vascular gland for the most part in hyperthyroidism. And then you have nervousness and a tremor sometimes. You can have anxiety. You can have trouble with anxiety, especially when you're going to sleep. Sometimes it's subtle. At night, we have all the time in the world to function on what we're anxious about. And some of you, without any hyperthyroidism at all in your lives, you notice that most anxiety happens at nighttime. In the day, you're too busy to focus on it, but at night, you notice it. You could have insomnia because it's so bad. If you hold out your outstretched hands, and sometimes you can emphasize it even by putting a piece of paper on it, you'll have a tremor. I'm making it a tremor, but this is a coarse tremor. It would be a fine tremor that you would kind of have with an outstretched hands from hyperthyroidism. You could have the bulging eyes. You don't have to have the bulging eyes, but bulging eyes is one of the characteristics of Graves' disease in particular. You can have frequent bowel movements, unlike the opposite with the hypothyroid where you have constipation and less frequent bowel movements. And it doesn't have to be diarrhea. It's just increased stool frequency, having more frequent bowel movements. There's an increased risk of miscarriage, and I should say that too about the hypothyroidism. There's probably an increased risk of miscarriage too. You could have a discomfort in the throat and difficulty swallowing, just like I said before from the hypothyroid patients. But the most important things, and this is why we're here today, is palpitations, tachycardia, and even irregular heartbeats, including atrial fibrillation, and we'll get back to that in a minute. Impaired fertility, weight loss, but sometimes weight gain. And that's because it can sometimes stimulate your appetite and change your metabolism, and 10% of people with hyperthyroidism actually gain weight. Heat intolerance. So you're hot in a room where everybody else is feeling okay, and that could happen from the menopause, but you can imagine the menopause on top of hyperthyroidism. And that happened actually dramatically when all the women across the country were terrified with the WHI study in 2002. Women across the country stopped taking their estrogen. The thyroid levels rose, and they not only had an acute case of menopause, but they also had an acute case of too much thyroid hormone if they were taking pills. Trouble swallowing. This is rare, but happens, the paralysis, especially in Asian patients who have a special disease of paralysis and muscle weakness. And again, a family history is predictive of this autoimmune disease called Graves' disease.
Okay. And so as I mentioned, I'm going to present some cases that I've seen here at NYU and some actually at Bellevue. It's louder. Okay. And so these are cases that I've either seen here at NYU or at Bellevue. Actually, one is at the VA. Okay. And so these are how these patients present and how we intersect frequently with cardiology. And so luckily, we also have a cardiologist here to answer some of the questions that come along with this. So I'll start out with the first case. I've got a 62-year-old male who came in for care for description of these progressive symptoms. The symptoms included that he felt like his heart was racing, he had shortness of breath, he felt shaky, and he complained of anxiety. When I saw him on exam, he appeared to me to be a very anxious male. His eyes were normal, though. He did have an enlarged non-tender thyroid, and I was able to palpate a 3-centimeter nodule on the right lobe of the gland. His heart rate was fast, it was irregular, his lung sounds were normal, and he had a fine tremor of his outstretched hands. The EKG, or the electrocardiogram, that's shown at the bottom corner of this screen, was consistent with a condition called atrial fibrillation, which is an irregular heart rate in the atria. And so when I asked him further about this, the patient had mentioned that he had recently been seen in an outside hospital, at which time he was given a CT scan, also commonly referred to as the CAT scan, for symptoms of shortness of breath. He said he remembers that they gave him an IV dye that made his body feel all warm all over. Dr. Greene, what do you think they gave him if a patient gave you that description?
That sounds like the iodinated dye, and characteristically most people feel this warmth all over their body after they get an iodinated dye. So if we're thinking of hyperthyroidism, which we are thinking of here, and we're thinking of a CAT scan dye, which has a lot of iodine in it, this could be a reason why we precipitated hyperthyroidism in this man.
Okay. And so he tells me that the anxiety and the shakiness started about 1 month ago. And then within the last 2 weeks is when he noticed these irregular heart beats, these palpitations. And so at this time, Dr. Greene, what would you want to see? What would you recommend that this patient have?
So one of the things that we do in a case of hyperthyroidism with a nodule would be first to look at the nodule under an ultrasound, and then possibly also, but it really depends upon the timing between the CAT scan and the present time, we might want to do a thyroid scan. The thyroid scan is a nuclear medicine scan as opposed to the ultrasound, which is ultrasound waves.
And so
we want to see, of course, his lab tests, which is what Dr. Baldwin is showing us now.
And so these are the lab tests, and so they can be a little bit confusing at first to interpret, okay? And so I'll have Dr. Greene teach you about how to interpret your thyroid function studies. But this patient, in fact, does have hyperthyroidism as shown on these labs, and also had a positive thyroid-stimulating immunoglobulin. And so hopefully Dr. Greene can clear up for us how to interpret these and what that would mean to have this positive antibody.
Okay, so first of all, I have patients saying all kinds of things, about their test results. So the first thing is really a nice pattern, which is the bottom pattern, which we have on this slide, which is that the thyroid hormone levels themselves, the T4 and the T3, could be high in hyperthyroidism. And in most cases of hyperthyroidism, 99%, also the TSH, which is the pituitary hormone called thyroid stimulating hormone, is low. So we have a low, okay, thank you. So we have a low level of the TSH, which is in this column in hyperthyroidism. And on the previous slide, we also saw this antibody, which is really interesting. In most diseases, when you have an antibody, it blocks things. But this is an interesting antibody in that it stimulates the thyroid. So it's not really the thyroid gland's fault. It is sort of the victim in this disease. In other words, it has a continuous stimulation by this antibody called thyroid-stimulating immunoglobulin. And, but this is not the case in this disease because this patient doesn't have Graves'. This is another cause of hyperthyroidism. So I told you before, and Dr. Baldwin told you before, that Graves' disease, which is Graves apostrophe after the S, meaning it's named for a man whose name is Graves. It's not a grave disease, and I have to explain that all day long to patients who, are about to go into shock when they hear they have a grave disease, or however they hear it. It's Graves' disease with the apostrophe after the S. But this is not Graves' disease because his antibody is undetectable. In Graves' disease, you would expect to see a high level of the antibody. This instead is probably hyperthyroidism coming from the nodule, but we need more information to determine.
Okay. And so as you requested, here's the ultrasound that we've obtained of this patient. And so ultrasound, we most commonly think of this test when we think about women who are about to have babies and they're following the fetus, okay? So very similar. It's sound waves that are used. Those sound waves bounce off of tissues of different consistency, and it's actually the most sensitive test for thyroid nodules. And so we frequently have people who go and get CAT scans, and they may or may not see something in the thyroid, and we'll say, actually, go back and get an ultrasound, because it's actually a better test. And as technology progresses, some of us even carry little ultrasounds around in our pocket so that we can take a quick look, okay? But of course, we try to keep up our physical exam to keep our senior faculty happy.
To outline the outside, and you can see it's distinct from the other tissue. I don't know how well you can understand this, but at the top is the skin surface, and there is normal thyroid tissue underneath this cross, surrounding it. So it's a nodule kind of indenting the normal thyroid gland, and I can't see the trachea.
Right, here's the trachea.
Yeah, there's the trachea. Okay, so the dark space over here is all trachea. And trachea is the windpipe, the air tube.
Okay. And so just as Dr. Greene had also requested, in order to prove that this patient's hyperthyroidism was coming from the nodule, we did a study called an uptake and scan. The uptake and scan is where we use iodine since we manipulate the fact that we know that the thyroid takes up iodine. The most active areas of the thyroid will take up this labeled iodine, and we'll be able to tell which part of the thyroid is overactive. And so, for example, in the past, they used to use these uptakes and scan to look for what are called cold nodules, or nodules that don't produce thyroid hormone. The reason we would think that is because those would be more likely to be a cancer, okay? But we have better tests for that now, and so less commonly used. Now, Graves' disease, you would see the entire thyroid light up, okay? Because that's the entire thyroid being overactive. If you had a toxic multinodular goiter, meaning multiple nodules that overproduce thyroid, you would see more of a patchy pattern, okay? And you would see it line up with the thyroid ultrasound. The nodules at the same place would be the overactive ones, okay? Here would be an example of one nodule that was overactive. And then here we can see where one nodule is so overactive that you lose the rest of the thyroid gland, meaning it completely shuts down because, again, that signal from the brain will be very low, no longer stimulating the thyroid gland. Okay? Now, in an opposite condition where the thyroid is just destroyed due to inflammation or something along those lines and just dumps out the thyroid hormone, it's not necessarily being stimulated to make more, you'll actually see a scan where you don't see any uptake in the thyroid. Okay, and so this test is actually rather helpful to us, and I'll show you this patient's uptake and scan and see what you think. Dr. Greene, you want to take it away?
Okay. Oh, I just did the wrong thing. I just turned it all off.
No, hold on, I think I can get it. There we go.
Okay, so here. So So this shows the highest uptake in this place and this place. This shows a uniform kind of uptake in one area, which would be similar to our patient in terms of palpation. Again, this is more like a multinodule, but only lighting up on one side. Again, this looks like an indented thyroid a little bit. So I would think that this was the red one?
Yeah, and so this patient had necrosis, or the center of the nodule had outgrown its blood supply and died.
These are all the same patient.
So it's a single nodule. Yep. Yep. And so again, that's consistent with this patient having overactivity in a single nodule. Okay.
There's only one caution I'd give on this, and that's that the patient had recently had a CAT scan, and the CAT scan did not have any radioactive material in it. It is a radiation test where you look at it, but with radiation. But sometimes if the CAT scan were too recent, you might block the uptake in this nodule. But assuming that the CAT scan was a little bit distant in time and the patient continues being hyperthyroid, that would be the kind of image you would get. And that would tell you that this is not Graves' disease. He doesn't have the antibodies that you would look for in Graves' disease. And he doesn't have the exophthalmos that you might see in Graves' disease, so it's instead a toxic nodule, which isn't as common at all as Graves' disease, but becomes a little bit more common as a cause as you get older. And another thing that gets more common as you get older is what's called the toxic multinodular goiter. That happens more in elderly people, where several nodules are lighting up.
And so this is frequently how we talk to each other. We say, what's your assessment? Meaning, when you look at this patient, what is going on? What is happening? And then secondly, we talk about what we're going to do about it, the plan, okay? And so our assessment of this patient was that this patient had hyperthyroidism, and it's due to a toxic nodule. It was likely caused by an exacerbation with iodine exposure when this patient got the CT scan with iodinated contrast. It was complicated by the fact that the patient had cardiac symptoms, meaning that the patient had atrial fibrillation. And so here's a couple of things that we might consider doing for this patient. And one would be, would you consider doing beta blockade? Or you might think of metoprolol. Those are propranolol, drugs like that commonly we use. Dr. Greene?
Do you have a cardiac opinion on it?
Come on.
So maybe I'll start with one question to the endocrinologist for a second. I think part of what our endocrinologist did was highlight how important is to take a history, because in the cardiovascular world, de novo AFib or coming to the hospital for AFib is what we consider bread and butter. It's dime a dozen. So they took a history, we take a history, but we sometimes don't always notice the goiters. We sometimes may not necessarily understand the significance of the CT scan a month prior and what that really means. So I think one thing outlined very nicely here is that it's still important to really think about everything in the whole patient, rather than just saying, okay, they have AFib, we're done, we'll manage it and move on. So that's the first thing I'd highlight. The second thing I would ask you guys is, this was a Bellevue, did this patient come from an area that had low iodine to begin with?
Not that we know of.
Okay, based on,
But that happens a lot at Bellevue.
Right.
We have a lot of patients from Southeast Asia, India, Pakistan, Bangladesh, who might be that kind of patients. We have to be careful, because those patients would be particularly predisposed to having an iodine exposure and then suddenly becoming hyperthyroid.
Right. So maybe that was out of my own curiosity, but as Dr. Greene said, that is something that we always have to think about. But anyway, so in terms of how we manage this patient's atrial fibrillation, we'd obviously ask the endocrinologist to weigh in on how the treatment of the thyroid condition would impact the AFib and control of the fast heart rate. But the way we think about AFib is we think of it from about three different ways. The first is the etiology. Is there an etiology we can pinpoint? The second is controlling the symptoms, okay? And the third is minimizing stroke risk. So I'll talk about the stroke risk first. So when you're in atrial fibrillation, I guess do we have a model of a heart here? We don't have a model of a heart.
We don't have a heart.
Okay. I think of the heart as the most important thing, and everything else is secondary to the heart. And that's actually, the one thing I would say is, as a cardiologist, we actually think of the brain as still the most important thing, and then the heart. And the reason I say that is because strokes are really bad. And when you have atrial fibrillation, the top part of the heart is going really, really fast, 300, 400 beats a minute. And the bottom part is still going a little fast. But when your heart goes that fast up top, you get what we call stasis. The blood's not, it's kind of just circling around, doing its thing. It's not really moving fastly through that area. And that predisposes you to building up a blood clot in that area. And so one of our core ways that we treat atrial fibrillation is something that you don't even feel. It's minimizing your stroke risk or giving you blood thinners to prevent that stasis, that blood from building up too much. Now, those blood thinners are based off of scoring systems that we have, sometimes things that we see in pictures of your heart. So it's not always an absolute. But as you get older, as you develop more cardiac conditions, we really think of the first step is thinning your blood. And that doesn't have to happen right away. Your stroke risk is cumulative over time, but it's something that we always think about right away. So that's anticoagulation for the arrhythmia. The second thing is rate control. How do we make you feel better? Because that's what you really care about. You feel crummy when you came to the hospital. And we like to slow down the heart. We're never going to be able to slow down that top part of the heart. It's going too fast, it's too crazy, it's too wonky. So we actually slow down the connection between the top and the bottom part. And we give beta blockers. We give a thing to slow down that middle part. And there's some discussion in the intersection of the endocrinology and the cardiology world of what's the best beta blocker to give. Cardiologists, we love metoprolol. It's a long-acting drug. We say it lasts for 24 hours. You know, we can get you on a lot of that. You can tolerate it. But some endocrinologists and some cardiologists, especially if you've been doing this long enough, think that propranolol may be just as good as better because it actually, maybe you'll talk about this, it actually inhibits some of the conversion from different activated forms of thyroid. So, you know, you will sometimes talk to endocrinology friends, but we'll get you on some heart rate lowering medication. And then we'll go to the etiology of it. We'll try to figure out why you had this. In this case, it was outlined for us nicely, but we'll do an ultrasound of your heart. We will check your blood counts. We'll check other stuff as well. And that's to help etiology, chronicity. A lot of times AFib that you come to the hospital with has actually been here for years and you just didn't know. So we'll make sure that we don't miss anything. But those are the three things that we'll do. We'll slow your heart rate down. We will do an ultrasound of your heart. And we will consider starting you on blood thinners. And then, of course, there's a whole nother conversation, which is for a different day, which is, should we get your heart into a normal rhythm? But we'll maybe stem that for a different conversation.
Thank you. That's very helpful.
So it's nice to have a team of doctors that each doctor thinks a different organ is the most important one in your body. And so, Dr. Greene, when we think about teaching the treating the thyroid, we also consider this medication commonly called Methimazole. Would you consider Methimazole in this patient?
Right now, that's the first choice drug. 20 years ago, PTU was considered the first choice drug to block thyroid hormone formation by blocking something called organification and also blocking at other steps. But what organification is basically taking in the iodine that's around and making it into thyroid hormone. Methimazole is considered the safest, and we use it in almost all cases as a first-line drug unless someone is allergic to methimazole or perhaps in the first trimester of pregnancy if a woman is pregnant and has an overactive thyroid. So it's our drug of choice. It can be given once or twice a day and is usually pretty long-acting. And if this patient has atrial fibrillation that we think is due to the thyroid, which I think is true in this case, we would try a higher dose and maybe bring it down to a lower dose as the patient is more stable. We have to watch for certain things like liver problems and white blood cell problems when a patient is on methimazole. Also can cause rashes. About 5% of patients get rashes, and about 5% of patients get some side effects, but we hope they're not the major side effects of liver problems or white blood cell problems. And that may be dose-related and also might be age-related. In other words, older patients might have a higher risk, and patients who are on a higher dose of methimazole might have a higher risk. And a third higher risk, which is sometimes reported, is patients who have been treated for hyperthyroidism in the past with this drug and keep on having it reintroduced. And that's probably true for many allergies, like penicillin allergy. People almost never have an allergy for the first time with penicillin. It's usually the second time with penicillin when they have their allergy. So the other things that we have listed over here are for later on. And we have to make decisions about the thyroid, whether this hyperthyroid should be treated with radioactive iodine. The thyroid gland is a stupid gland in many ways. It doesn't know radioactive from plain iodine, and radioactive iodine is happily taken up by the thyroid gland. It doesn't know any better, and then it leads to a destruction. It doesn't lead to a destruction like the thyroid gland explodes, but it leads to a slow destruction. But it's kind of slow, and it might be too slow in our case, but on the other hand, we don't want to do anything dramatic in an elderly person. So a lot of this depends upon the age of the patient. It also depends on other things, like if this is a young patient who's a woman who wants to get pregnant, we might not choose this way of treating her. Especially in younger patients, hyperthyroidism often goes into remission. That's under age 35. And older patients, it usually stays or recurs, and it's much more of a problem. Surgery is a good alternative in a younger, healthier patient otherwise, but not with atrial fibrillation in the background until you've controlled everything else. But surgery can be used, but you have to bring down the thyroid levels first before you can treat the patient with surgery.
Okay. And so here is a chart that we pull out of a review that we use when we think about the hyperthyroid state and cardiovascular function. And so largely what we're saying is that the heart works harder because it gets signals to increase the frequency of the heart rate. The cells of the heart can enlarge because they're working and pumping harder. And also the vascular resistance can also change, causing overall more work on the heart. Okay. And so, again, the most common manifestation is that somebody will have a fast heart rate, okay? They also can say that they're fatigued and have shortness of breath, and that's, again, due to the increased work that the heart's undergoing. Atrial arrhythmias, when we were talking about the top of the heart beating in an irregular fashion, including atrial fibrillation, are more common to manifest in our older population of patients who have this condition. Prolonged untreated hyperthyroidism can result in heart failure. Okay? If that heart works too hard for too long, eventually it will show signs of fatigue and heart failure. Okay.
I love this slide because it shows you when to be scared. Scary slide. So I've had a number of patients who over the years have liked to be slightly hyper. Why? They can lose weight, they feel it's wonderful, but it's not wonderful to keep yourself hyperthyroid or mildly hyperthyroid. It really needs to be treated for two major reasons. The first reason, I think the most important reason why we're here, is the heart. This leads to an increase of atrial fibrillation, especially as you get older, even with slight lowering of the TSH, the pituitary hormone, meaning the thyroid is slightly overactive and suppressing it. The other reason, which we're not here for, but I'll mention because I like it, is osteoporosis. Osteoporosis has increased risks, and it's not on this slide, but this is showing you the atrial fibrillation risk of having it. So a person with normal TSH, meaning not suppressed at all, not having too much thyroid, either taking it as a pill or having it naturally, is in much lower risk of having atrial fibrillation. This is a sort of in-between slightly low TSH, and this is the population with too much thyroid hormone, either naturally or exogenously, meaning you're taking pills with too much thyroid hormone with an increased risk of atrial fibrillation.
Okay. Can we take any questions on the hyperthyroid state in the heart?
I don't think we have time for questions.
Yeah.
I think we should. What? I think we should come to the questions at the end because it's 7:25. I'm just reading over there, and I think we want more to do on hypothyroidism, and then we'll stay and take questions after everybody who wants to get questions stays.
Hopefully you're able to get that. Okay, so we'll move through hypothyroidism. So this is a patient presented to Bellevue, a 66-year-old female, and she said, or her husband was the one who gave the history, and this patient had slurred speech, was unable to care for herself at home, stopped doing her normal activities of daily living. Her history was notable for having a condition of hypothyroidism, and she was supposed to be taking 150 micrograms of levothyroxine, which is the standard hypothyroidism medication. She had no exposures that put her at risk for thyroid disease beyond that. And on exam, I saw a lethargic, meaning very tired, obese female. She had facial swelling, especially seen around her eyes. She had no enlargement of the thyroid gland. Her heart rate was quite slow, and I had a difficult time hearing her heart sounds. She did have a wheeze, meaning I could hear a whistling sound when I listened to her lungs. Her skin was incredibly dry throughout, and she had, when I tapped on her reflexes, a very slow, delayed relaxation of that deep tendon reflex. She was actually admitted to the ICU in respiratory failure. And so I was called to the bedside to see this patient because of these very abnormal thyroid function labs. And if we remember when Dr. Greene went over this, high TSH actually reflects the brain saying, give me more thyroid. And then these low free hormone levels suggest a hypothyroid state. This is a different antibody that was, we get very excited about at a number this high. This patient has some pretty serious autoimmune disease. Which autoimmune disease, Dr. Greene, would you think?
This is characteristic of what we call Hashimoto's disease, and in some people it's on a gradient between Hashimoto's and Graves. But what I want to say about this antibody is it's probably not doing anything. There are a couple of conditions where it might be acting to block, but those are rare conditions that you don't have to hear about here. Most people who have this positive antibody just have destroyed or defective tissue in their thyroid gland, and the antibody forms in response to the destruction. It's a marker of the destruction. It helps us call it Hashimoto's disease as an autoimmune disease, as a cause or etiology of the thyroid, but it's not responsible for anything. So it doesn't matter. Someone's going to ask me, my antibody level is very high. I don't care how high it is. If it's a little high or very high, it doesn't mean anything. And when you get treated, the antibody level may still stay very high. Again, it doesn't mean anything.
Okay.
So the most common cause of thyroid lowering or hypothyroidism is Hashimoto's, which I'm saying. Again, it's more common in women than in men. And it's a much more common disease than the Graves' disease. So this is a more common disease. The prevalence, again, increases with age, with women getting it more than men. And the treatment is basically thyroid replacement. And gradually that should shrink the thyroid as the TSH, the pituitary hormone, gets lower and stops stimulating the thyroid. The thyroid shrinks in response to the lowering of TSH.
Okay. Now, because this patient had difficulty to hear heart sounds, our cardiology colleagues were quick to have also the bradycardia and this new onset wheeze, wanted to have that ultrasound of the heart, okay, an echocardiogram. And so maybe we'll have input from the cardiologist. This might be something they would get rather excited to see.
So I guess in the interest of time, we'll go fast, but this doesn't move, does it, the picture? No? Okay. So, there's marked fluid around the heart. We have these what we call theoretical spaces where we have this lining of the heart, and there's a little bit of fluid in there to help lubricate things, but if the fluid builds up and builds up and builds up, you get just a massive amount of fluid around the heart. And this,
so this is all
right,
fluid.
right, all that black is
all
fluid.
the black
Yep.
is surrounding a heart.
Yeah, and that shouldn't be there. So if the fluid builds up very fast, that's extraordinarily dangerous. If the fluid builds up very, very slowly, that's usually not dangerous at all. And so I didn't hear a heart rate or blood pressure in the physical exam, but she was admitted for respiratory failure, not hemodynamic instability. So if that's the case, we would note this and we'd say, okay, sounds good. And, we wouldn't.
Slow accumulation.
Right. Oh, good. Okay. So, we wouldn't, with times we would really want to do something about this if we didn't know the reason or if it was causing a hemodynamic problem.
And so That's a great point, because oftentimes we can see this and be a little bit nervous since it is such a large amount of fluid. But the important part is to know that this didn't happen overnight. The thyroid is probably a very slow condition, and so therefore we can kind of relax, especially if we see that the blood pressure is maintaining at a normal rate, meaning the function of the heart has been maintained. And so this case is bizarre and interesting for the fact that because it's such a slow accumulation, we adapt, okay? And so the heart is able to pump forward the amount of fluid. Typically, it's not able to create enough pressure to cause any problems because it was so slow. But this patient is actually a case reportable. We're in the midst of writing this case up and publishing it for the fact that it did cause quite an impressive finding where we can see our windpipe breaks into two and goes into each lung. This was actually a large enough effusion that it caused compression, and I'm pointing right to it. Usually you should see a nice round wind tube, and this was actually able to compress it, okay? So quite an extreme of thyroid manifestation on the heart. Okay, and so this patient was likely non-compliant, okay, and that's the number one. So there used to be studies that suggested that this could happen up into 80% of patients who had hypothyroidism. Well, now that we are able to recognize this condition so much quicker, it's really more like 3%, okay, and the most common time that we ever see it is actually when people just aren't taking their medicine. Okay, and so this patient did have a severe presentation of hypothyroidism. She actually became much more alert. I see her walking the hallways sometimes, and I wonder if she even recognizes me, but I remember when she was very, very sick, and now she looks like a new woman, okay? And that's just with the replacement of thyroid hormone. We really shouldn't have to do much else for patients with huge effusions like this, okay? Here goes into much more depth about all of the effects of hypothyroidism, but maybe we'll...
Just in the interest of time, do we have time? We're good?
Yeah, we're good.
Oh, okay. So we'll go through a few of these. I guess one of the comments I'd love to bring up is we talked a lot about hemodynamic consequences of hyper and hypothyroidism. But, we're in the prevention center, and I'm a preventive cardiologist, and wondering if you guys could briefly talk about the lipid abnormalities in cardiovascular disease and thyroid. And I guess I'll ask a question. I have high cholesterol. Should I have my TSH checked?
Okay. And so, high cholesterol is incredibly common in the general population. And so it'll be much more common to have high cholesterol due to your diet, genetics. And so many people think that statins, I'm sure many of you have heard of those drugs, should be in the water, okay? I'll leave that to cardiology to say whether or not they agree. But it's much more likely that is the problem than it is your thyroid. It is true, however, if somebody has maybe normal cholesterol levels when they're high thyroid, we're very aware that we need to recheck that thyroid or those cholesterol levels months later once we've treated the thyroid condition, because likely the cholesterol levels will rise, okay? And vice versa is true, okay? Meaning that the low thyroid state, we would hope that the cholesterol levels would improve, okay?
Question that I have, because as you point out, we're dealing with two very, very common conditions. And, of course, I do think everybody has high cholesterol, and we we think a lot of people do have or we check thyroid often, and I'd say in the cardiology world and in the primary care world in general. So it's nice to hear that interaction between the two. I guess the other question I have. So I have very severe cardiovascular disease. I have multiple blockages in my heart. I'm on an aspirin. I'm on a statin. I've had my stents put in, and my thyroid is just a little off. I don't know. My TSH is just a little off. I guess we'll start with maybe my TSH is a little low. I have my thyroid just a little too high. Or we can start with the opposite. My TSH is a little high and my thyroid is just a little sluggish. Is that going to save me?
What I've read in HERS, which is the famous cardiology textbook, it's not a thyroid textbook, is they did a big study of many people with underlying cardiovascular disease, and they treated them all with thyroid hormone if they were slightly low. And 1/3 of them got better, 1/3 of them stayed the same, and 1/3 of them got worse. So I don't know the answer to the question. I would just say that if somebody has cardiovascular disease, we start very slowly,
Right.
and we're allowing people who are older to have slightly higher TSHs. When I was in medical school, the dogma was let older people have a higher TSH, be slightly hypothyroid. Then after that, the dogma was older people should be the same as younger people in their TSH. Now we're bouncing back again to letting older people have slightly higher TSHs. The person who's really the proponent of this is Dr. Sirks, who's chief of endocrinology at Montefiore Hospital, and has done a lot of cardiovascular work. But there are other people at the other extreme. Dr. Irwin Klein has proposed giving T3 to people during a heart attack. I think that's fairly scary, but he proposes that it helps cardiac dilatation of the vasculature, and he feels that that's a good idea. I disagree, but I'm more conservative than he is about the heart.
So what you're saying is we don't really know.
I don't really know.
Okay.
Do you know the answer?
I don't. I was going to defer to you. I mean, my teaching has been that if someone has severe cardiovascular disease, to go slow with a thyroid replacement hormone. I think we're dealing with a slow disease. And, it's a similar paradigm with treating lipids. We think of lipid.
Use statins before I push the thyroid.
Yes, I am, in the prevention center. We are big proponents of disease modification agents like cholesterol-lowering medications for prevention of cardiovascular disease. So I think that's a very good concept. I guess, the other question I have for you, and I'm kind of just using clinical examples as we go through some of these cardiovascular manifestations, we'll talk about maybe some of the ECG changes. So ECGs, for those who are not familiar, we can measure electrical signals in your heart, and we can reap a lot of information off of those electrical signals, how the heart's beating, the sickness of the heart. But we also give drugs that cardiologists give a lot of drugs that can do stuff to the electrical system. And one of the drugs we have, amiodarone, we frequently reach for in our older population because for whatever reason, we think it's very, very safe, even though it has a lot of side effects. And it has a lot of thyroid side effects. So I'm wondering if you guys could talk about that a little bit, and should I be, and I'll ask that question in the modern era, and not in the circa 20 years ago era when we were giving whopping doses of amiodarone, but now we give a lot lower doses. And we found that those lower doses are effective from a cardiovascular perspective. So should we be worried about amiodarone in the thyroid in the modern era?
And so that's we could have a full-time job off of amiodarone and the thyroid, okay? And so this drug is incredibly commonly used. I remember being a resident and thanking God for having amiodarone because it could really save lives, okay? But as a thyroidologist, you do see that it has pretty much any effect you can think of when it comes to the thyroid, you can have it, meaning it can cause it to be inflamed, overproductive, underproductive, and sometimes the treatments are not as clear-cut, meaning diagnosing what's actually happening is difficult, but there's really never a time where we're going to say absolutely don't give it. You save the heart rate, you save the patient first, and then we can do pretty much, we can figure it out when it comes to the thyroid, okay? And so while it's a complicated medicine and it keeps us on our toes, it's absolutely life-saving, and so it needs to be used at times, and we can deal with the consequences.
The other thing I will say about amiodarone is it lasts an incredibly long time, so you really have to deal with it before you can get it out of your body. The iodine has profound effects for quite a while after it's given, so you can't just say stop it and that'll help everything. Usually you have to deal with the atrial fibrillation first, as you're saying, and if it's amiodarone, it could be amiodarone. But we've seen patients even who have had both hyper and hypothyroidism in the same patient from the amiodarone. And the hypothyroidism is very easy to deal with. The hyperthyroidism is much more difficult. And we can treat a patient like that with radioactive iodine because they're full of iodine and they'll be full of iodine for months. We usually don't want to be doing surgery on these kind of patients because these are risky patients with atrial fibrillation who are not great surgical candidates. I hate that term, but you know what I mean. It can be very challenging, and sometimes a patient is in the ICU for this